Okay, good morning to everyone. I'm going to uh, talk a little bit about why we should be teaching primary care psychiatry instead of psychiatry. Uh, Just for introduction, I'm a professor of psychiatry at University Tunku Abdul Rahman, which is in Malaysia. I'm speaking from Malaysia. I'm a professor of psychiatry there. And I've been teaching psychiatry for many decades. And all the time, the teaching has been based in mental hospitals or mental wards. But at the same time, it is well known that psychiatry uh, is more than just the kind of patients we see in a psychiatric ward or a psychiatric hospital. So, without further ado, I'd like to just give a little more introduction. The logo of my uh, university is here, UTAR, University Tupan Rahman. And on the right-hand side is a logo of the Asian Federation of Psychiatric Associations, which I founded in 2005 with the aim of actually uh, improving the practice of psychiatry, which should be more inclusive than just seeing patients with severe psychotic illnesses. Psychiatry is a latecomer in teaching in medical schools. Unlike medicine, surgery, gynecology, and so on, which actually much longer history. The teaching of psychiatry only came about late in the 19th century with entrance of people like Freud and many other famous psychiatrists. They started to understand that mental illnesses were not due to some strange, magical, supernatural causes and so on, but actually due to psychological stress of some sort. Many of the early theories have now not lasted very long, and more of biochemical theories have taken over. But nonetheless, emotional stress in people is far more common than the psychosis we're talking about. Psychosis is very severe, very dramatic, and very frightening, and of course needs a lot of attention because people can get, sometimes not always, get dangerous and violent and aggressive. But there are lots of other people suffering continuously from stress caused by problems at work, money, families, marriage, work problems, all sorts of things, which do not lead to psychosis. We do not lead to dangerous consequences of mental stress, like, for example, schizophrenia or bipolar disorder, or again, mental disorders due to accidents and brain damage and so on. Those are dangerous, important, and need to be managed. But at the same time, we need to go beyond that to look at the very important causes of daily stress. Daily stress. And for a long time, even that difficult, dangerous psychotic conditions were not managed properly because we did not have medicines. Only in 1954, the DeLay and Dannecker, two famous scientists, discovered chlorpromazine, which could control the aggressive behavior, not cure the disease, but control the aggressive behavior, which could be managed with the new medicines in the 1954. It rapidly became available all over the world. We are a modern world now, very easy to spread all these medicines, and rapidly followed by antidepressants, anti-anxiety drugs, and so on, so that the consequences of psychotic diseases, consequences of psychological problems, of emotional stress, people like couldn't sleep properly because they were under stress, all were relatively well managed symptom-wise. The symptoms of these so-called stresses, psychotic disease, and so on, could be managed by medicine. But the concept that mental illness is madness, is people are crazy, violent, aggressive, dangerous, unfortunately has continued despite the advances in medicines available for the treatment of psychiatric illnesses. So the incarceration or locking up of mental patients, of the mentally ill, to safeguard them from abuse and safeguard people outside, still persists till the 21st century. The ignorance regarding the reality of mental illnesses, psychiatric illnesses, or stress-related illnesses, unfortunately, is still not properly accepted, understood, or practiced. Freud awakened the interest in psychiatry in the late 19th century, trying to afford explanations and followed by many others in Europe and America. Psychological explanations followed, and later biochemical theories and psychosocial models followed. Teaching in medical schools included psychiatry in the early 1900s. Before that, psychiatry was not considered part of medicine. In fact, psychiatrists were known as alienists because we are alienated from the mainstream of medical care. So teaching did not include psychiatry. It was only in the mental asylums, locked up. It was actually closer to prisons than to medical schools. But gradually it's changed. So even in the LAMICs, low and medium income countries, actually medicines were available by the 1960s or 1950s, late 50s. It was available in Malaysia. Chlorpromazine was available in Malaysia in the late 50s. Before we became independent in 1957, we already had chlorpromazine. But the fear and the prejudice and the wrong concepts about mental illness meant that mental illness only psychosis, the rest is not mental illness. So anxiety, depression, stress were not considered part of our treatment till today. When it's there, nobody knows how. The primary care people don't know how to manage it. The psychiatrists are dealing with the psychosis. So who's going to deal with the stress-related illnesses? Good question. So this is a typical mental hospital of the 1950s. At the time of independence, this was how the mental hospital looked. As if that's all there is. And then in the late 50s, small psychiatric units started in general hospital, which was a big step forward, where small hospital had small psychiatric units. But the units were like what you see on the right. They're little cells, jails, and then collect the patients and send them to the large mental hospital, which had as many as 5,000 patients in 1970. Biological theories predominate, unfortunately. I say unfortunately because although they are tremendous advances, their theories are so strong on the biochemical theories at the expense of psychosocial models of origins and treatments in psychiatry. Teaching also focused on the phenomenology, psychopathology of severe illnesses, ignoring or reducing focus on stress and distress affecting daily lives of people everywhere. Thus, express excessive focus on reducing symptoms, not only increasing improvement in functioning, improving personal, emotional, and family lives was a problem. Teaching settings, that is the paradox of uncommon illnesses versus common illnesses. As psychiatry started to move into curricular development, countries that remained wholly or largely poorly run institutions, where security and safety was more important, and concern and caring for the distress that patients had was not so important. The main requirement for admission to mental hospitals was patient had to be dangerous. What about those under stress? Well, that's not important because it's not dangerous. So he's manageable. How he manages, that's up to him. Teachers and guardians of the ill often were posted to the psychiatric wards where they themselves ran foul of their health administrators. Mental wards existed before proper treatments were available. That's the truth. That chlorpromazine only came in 1954. Before that, there was no proper treatment. There were all kind of malaria treatment and all kind of things, but basically were not very effective. So movement from incarceration of mental patients to medical treatments was slow and took a long time to occur. Indeed, it was only in 2001 that the World Health Organization, WHO, report of 2001 actually recommended that psychiatry be taught in the non-institutional settings in primary care. That was a paradigm shift because until then, everything is important was to do with psychosis. Here was, psychosis is important, but we also need to look at the primary care setting where lots of people under stress. What is now people are concerned about NCD, the non-communicable diseases, a lot of stress, not just post-traumatic stress, which we talk about, but much, 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 much more. People who are migrants moving, a lot of stress, family stress, COVID, lack of money, lack of occupation, unemployment, marital stress, divorce, separation, all kinds of stresses, which do not lead to psychosis. Mind you, no psychosis, but they're equally important. And actually data, this is quite recent data in 2017, I think, shows very clearly that depression, anxiety disorders constitute 264 and 284 million people. Total number is 970. So you take away this more than 500 million people, you find that more than half the patients with mental illness had non-psychotic illnesses, depression and psychosis. Depression and anxiety. And psychosis, like bipolar disorders, schizophrenia, organic mental disorders, were much, much less. And these figures show very clearly that even drug addiction, alcoholism, were much more than schizophrenia. And yet, that is not given as much importance as schizophrenia. In the ICD-10 and now ICD-11, somehow, for obsessional reasons, we have stuck onto the psychosis as the description of psychiatric illnesses for medical students and nurses. So we need to change that because the majority of people are suffering, not psychotic, but they're equally affected by the many stresses of life and in fact contributing to the non-communicable diseases. Current mismatch in teaching of psychiatry is taught on fewer severe cases of psychological problems and severe depression. About 7% of all mental illnesses is the psychosis, ignoring more common anxiety, depression, stress-related psychiatric illnesses, about 65%. Reasons: logistic problems of severe patients, although rare in the community, are more common in the psychiatric wards. What happens is there's a big logistic problem. Because the psychotic patients are quite severe, we need to treat them somewhere. We can't just leave them on the streets because they're quite dangerous or dangerous to themselves and danger to others. So what happens is you have a ward, put all these dangerous fellows inside. In that process, we slowly ignored the non-dangerous but far bigger anxiety and depression cases, or what we call stress-related cases. That's why I say that even when you start a psychiatric ward, you should call it a stress management ward and have a small number of beds for the psychotic patient and more number of beds or outpatients, largely outpatients, for managing the stress-related problems. The continued mismatches, no psychiatric ward for psychiatric stress disorders. This is the reality. The reason why this anxiety, depression cases are not taught is that there's no ward. Outpatient, well, they come and they within a few hours they're gone. Shouldn't require time, take 1 hour, 2 hours to clerk the patient, examine the patient. They are too busy to go back, so they don't want to go back. So almost as if psychiatric cases is a psychotic case. Although the numbers are small, because the cases in the ward are mostly psychotic, we teach psychology. So time and again, in every developing country, we have this situation where the psychosis is largely dealing with the psychotic illnesses. The psychiatric problem, the psychotic illness. WHO says that 20 to 30% of primary healthcare patients have significant psychiatric problems, but not psychosis, problems that need treatment. But few primary healthcare doctors, including those who are involved in the primary care setting, actually have diagnostic categories known to them very well, or the management. Another mismatch is that even WHO only came out with ICD-10 primary healthcare in 1996. Its use has been slow, and now they have the MHCAP version, number 2, also been slow and not quite accepted everywhere. Trainee psychiatrists are not taught primary healthcare psychiatry to support the primary healthcare colleagues with this big, huge area of stress-related illnesses. Trainee family physicians not taught primary healthcare psychiatry. In fact, the most modern paperless hospitals in Malaysia have avoided psychiatric inpatient units. It took a long time. No psychiatric beds built without space for psychiatric clinics. So the ICD-10 primary health care of the WHO actually has come out with focus on primary health care psychiatry. I've got a slightly modified version myself on anxiety, depression, psychosis, substance abuse, and child psychiatry. So I don't know what they call the Lima system, which means 5. Logistic blocks in the teaching of primary health care psychiatry are no space, no staff to see stressed patients in primary health care clinics with 1,000 to 1,600 patients every day in the clinic. But there's no space. Doctors are busy with physical illnesses and don't know how to fit in these stress-related problems in their daily work. No dedicated primary health care psychiatric training, biopsychosocial approach, and to stress management in the primary health care sector. No teaching in interview skills, mostly physical examination approach. Nurses very busy, not trained to detect these primary health care problems. And psychiatry equals psychosis kind of approach, which is wrong. Primary healthcare psychiatry related expertise and staff are not available. This is a reality. Primary healthcare is very busy with physical. The psychiatric part is limited. Psychiatrists are very busy with psychosis, but they're not dealing with the primary healthcare so much. So that to find a primary healthcare clinic dealing with psychological problems, stress-related problems, non-psychotic, very difficult. So social workers, psychologists, occupational therapists also who are required for this primary healthcare stress management kind of approach, not available, doesn't exist. Now slowly some psychologists are coming in, some physiotherapists are coming in, but not yet the psychologists and social workers required for primary health care, like stress management in the family, marital problems, money problems, and so on and so forth. Day treatment for community-based care, group therapy skills, relaxation therapy, occupational therapy, marital therapy, all these are non-existent for most of the time. Day centers used as permanent institutional care, institutional day care, not as psychosocial rehabilitation centers to rehabilitate the patient. Over 25 day centers in Malaysia in Ministry of Health, and at least 25 in the NGO sector, which are more to do with community-based, have become babysitting services for chronic patients, but no forward movement. A paradigm shift is needed. On the paradigm of psychosis is not all there is in psychiatry. Psychosis, yes, important, but not all. The bigger, much bigger problem is to do with stress and primary care psychiatry. Psychiatry teaching to nurses, doctors need only to deal with the psychotic emergencies. But actually, they should deal with all of them. No need for counseling skills. This is the approach. But actually, counseling is very important and rarely taught to nurses and doctors. Psychiatry and mental health are part of the definition of health. According to the WHO, it says that it's not only physical health, but social and psychological health. Need rightful place in the services planning and implementation, including training, curriculum, service delivery, and integration of wherever psychological complications of intensive paradigm shift in priority and allocations from WHO to national level, for example, NCD and mental health. Basically, we need to take into account it's not just something separate. It's related very closely to the stress. And many of the NCD practices like over-smoking, drinking, obesity, overeating, and all that, very often precipitated by stress. And so when we say how to reduce NCD, we also look to the area of how to reduce stress. Stress does not only occur in wars and COVID pandemic. It occurs every time, all the time. So how can we reduce it? So how to change the psychiatry teaching in the 21st century? You can look at this first slide, which shows that all kind of clinics, very modern hospital in Malaysia, but no psychiatry clinic. How come? Well, that's one of the defects in the whole system. So Malaysia had a busy primary care clinic in Ampang, at least 1,600 patients. And there's a need to address the needs of these patients who are stressed, but not necessarily psychotic. We did that in Fiji in 2011. How many of these patients in Malaysia are actually stressed, may contribute to NCD, and may be requiring some psychological help? Who is going to build the primary health care psychiatry CAT? So what happened was we actually started a stress management clinic in UTAR. In the primary health care center, they gave us some space. Very nice of them to have cooperated with us. And we set up a stress management clinic. We don't call it psychiatry clinic. We don't call it mental health clinic. We call it stress management clinic. So we changed the name as well. And the students are there who helped to get this done. So stressor equals worry, insomnia continues with self-treatment. So NCD, overeating, drinking alcohol, and so on and so forth. So the need to detect and treat stress-related human problems before treatments can cause damage, but rarely taught to medical students. So we need to make that shift. NCD lifestyle or life stress diseases are very important, ignoring about the tobacco or stress-led problems. We all know this, that smoking is bad. People are still doing it. Why? Because most of them are stressed. Common sources of stress in 2 years study in KK Ampang, in the stress management clinics: poverty, retirement, dwindling social assets, support, leading to very common symptoms of insomnia. Insomnia is the biggest single complaint about people under stress. Family-related stress, children, property, rivalry, marital problems, relationship problems, stress, divorce, work-related stress, and study stress, and so on. So what we did was we started in an empty space was given to us in the primary healthcare center, and get them involved in looking at stress-related problems in non-psychotic patients. People come with can't sleep, can't cope, feel tired, blood pressure, but the blood pressure is not very high. They can't sleep. They're worried. So finally, for lack of space, the sister gave us a small space to use in the clinic. So you have to think out of the box. We cannot go on like this. So after getting some help from the clinic, we managed to get a space, small space, and buy a container with a roof given by the staff. We had to think out of the box, like this baby thinking out of the box, and start this stress management clinic. So students came and helped us, and similar to what we did in Fiji, we also started a stress management clinic. Students got the furniture and all that, and for a cost of less than $1,800 or about 7,000 Malaysian ringgit, we set up the stress management clinic. And this is the inside of it. Doesn't look like a psychiatric locked up ward, with a soft opening. And we had, we could not only teach, but we also showed films, teaching, training, and relaxation techniques done by the students. And just to get you excited on this, for those of you who love cats, I used the lima, like the paws of a cat. Psychosis, depressive illness, anxiety disorders, and all other subheadings, and child psychiatric disorders. Now, despite COVID, we continue with this same stress management techniques, and we use a hybrid method. Some students are in the stress management clinic because of distancing. They wear masks and everything, sanitize the place after every patient comes and goes. And we also have another set of patients observing this online. And after 2 hours, we switch over. They come back and this one go back. And so we're still continuing. We need not give up on, because most of psychiatrists do with history taking and counseling and all that. We also teach the students and the patients relaxation techniques. So thank you very much for listening. This is an idea. I hope that nurses and doctors and medical students will eventually use stress management as the mainstay, as the main part of psychiatric teaching and practice, and use the psychosis mostly for severe postgraduate kind of approach, how to manage the difficult patients. But they are usually difficult patients. So the number is only 7%, but they need specialized care. It's something like, say, specialized cardiology and general practice cardiology. That is the approach. Thank you very much. The email is there. For those who are interested, you can contact me by email. I'll be happy to.